Okay, today we're just going to review the quick scan. Only this time we'll find a major fixation in the thoracic spine, and then we'll go through adjusting again around the gang sign, flexion, extension, around the x-axis, rotation around the y-axis, and lateral flexion around the z-axis. The difference here is that quite often the sympathetic facilitation arises from the thoracic spine, and we should be able to elicit, if there is facilitation, a perspiration reflex. We'll do skin rolling and find it's exquisitely painful. If you had a pin, you would see there was hyperesthesia. The pin would be more sharp one side than the other. And from taking that area through a number of ranges, you're going to see a red reflex if there is facilitation. So facilitated sympathetics have a lot to do with the general health of a patient and the whole stress response. And hopefully you've read The Stress of Life by Hans Selye, or Why Zebras Don't Get Ulcers by David Sapolsky, or Sapolsky, and you'll understand a little bit of physiology and how it all stems from your body using the sympathetic nervous system to start the response to overcome bacteria, other kinds of stress, psychological stress, whatever it might be. And we believe that the spine can also produce those kind of stresses. Okay, so what we'll do is we'll place the patient in a nice neutral posture, little lordosis, little kyphosis, little cervical lordosis. And here the ligaments are at zero coefficient of friction, so we'll be able to just very gently push for nutation, feel it come back for counter nutation, right sacroiliac, left sacroiliac, turn sideways so we can feel whether the lumbars are going through that nice little jiggle. Not hyperextending, not flexing, just jiggling it in neutral, up through the thoracics, into the cervicals. Some of you might find you can't feel the upper thoracics as well. Just place your hands there, and you can actually do it. It's more of a hyperextension, but you'll find out whether that part is moving properly or not. So what we're going to do is we're going to assume we found something in the cervical spine, and now we want to see whether, by hooking on here, being to the right of the spinous, rotate P to A on the right, and see if it's springy. Come back. The first little bit of extension is extension of the posterior joints. Hook over the other side of the spinous. You're blocking the spinous and seeing if there's lateral flexion. And here we've got a little block in lateral flexion. It was moving beautifully extension, P to A rotation. Now we switch hands, put our thumb to the left side of the spinous, rotate forward, P to A, little extension, thumb to the right side of the spinous, right lateral flexion. And now he flexes very easily to the right, whereas on this side he blocked going over to the left. So the specific adjustment for him has to be left lateral flexion. If you do an ordinary adjustment of extension or rotation, you'll be able to palpate that he still has left lateral flexion. So specificity becomes restoring the function that's lost, not just getting a crack out of some part of the spine. It's much more specific than that. So if all you're doing is one crack at one level and calling that an adjustment, that might be cavitation, but is it a therapeutic adjustment? And as you know, at the very beginning we discussed the difference between adjusting a therapeutic adjustment, which changes the function, influences the closed kinematic system, has an effect on the whole locomotor system, as opposed to cracking one that's already mobile. It doesn't do anything to the locomotor system. It doesn't reduce any irritation to the nervous system. It's just a cavitation. It's what I call a non-therapeutic adjustment. So we need to have therapeutic adjustments. That's why we palpate specifically. We then feel the interspinuses separate for flexion, and we hyperextend to see if the anterior ligament is allowing the front of the body of the vertebrae to open. So the joints lock in an extension, and then we go further for hyperextension to see if we can feel a springy end feel. Another way to do this quick scan, would you come and lie down in a Sphinx posture? If your patient lies like that, and you take the heel of your hand, you can feel whether or not there's a springy end feel all the way down through the thoracic spine. And if you get to him on this junction of thoracolumbar, there's a little block there. And when I find a block, I ask the patient, can you feel a little pain there when I do that?
Yeah.
And the patient says, yes. Does it gone now that I've taken the stress away? He answered yes. So now we know we have the pain response of a manipulable lesion. If it was inflamed, the pain would linger, and we wouldn't be adjusting there. We'd be treating it for an inflammation of the posterior joint. Could you lie on your side? That's it. There's one more method for finding out whether the upper thoracics are moving well, and that is we cradle the head, have the patient in perpendicular to the table, and we can move the head and palpate the spine and see whether it's laterally flexing, extending, and you literally can feel between the thoracic vertebra and even as low as where I felt that left lateral flexion, which was right about there. Okay, so we have the quick scan, we have the Sphinx, and we have this head support to see and to get an appreciation of whether we need to adjust this patient's thoracic spine or not. The thoracic spine is extremely important for the cervical spine. If you can't extend and move in your thoracic spine, your cervicals will start to become hypermobile. They'll get inflamed, muscles will spasm, and then you get hypomobility with defensive splinting due to the inflammation that's there. So you often have to go back in the kinematic system, find where the dysfunction is that's setting up the symptom patterns at some other level. So I would suggest you always look very carefully, not only at the upper thoracics, but the thoracolumbar junction as well, which has a great influence on the lumbar spine. The upper thoracics also affect the lumbar spine. If we can't extend, say a baseball pitcher is going to throw and he has to extend his thoracics, if he doesn't do that, he's going to hyperextend his lumbars. And so he'll start compressing those facets and he'll develop an inflammation of the posterior facets and get a nice facet syndrome going that'll take him off the pitcher's mound. The shoulder, if it tries to make up for that lack of extension of the thoracics, it's going to start functioning incorrectly and you'll start getting inflammation of the tissues in the shoulder, tendons, capsule, whatever. Okay, I'm going to have you lie face down for me. Now we've talked about the sweat response and this we showed skin roll in the lumbar spine. I want to show it here in the thoracics. Again, you roll the skin with your fingers, your thumb slides. So it really should be called thumb sliding, not skin rolling, because it's the sliding thumb that elicits the exquisite pain, not the rolling of the skin. So if I roll along like that, my thumbs are dragging behind and they're irritating. Where it's facilitated, it'll turn bright red in a nice red reflex. So let's now assume that we have to adjust P to A rotation in the thoracic spine with a cross bilateral. So you can feel where it's resisting. Take out the skin slack. Make a pisiform so that you're bending your wrist, cocking your fingers, and putting the pisiform right in over top of where this hand took out the skin slack. Now cross, and this is why it's called cross bilateral. Cross over and create a little side tension. Set yourself so that your pelvis is going forward. Drop in between your shoulders and come up and drop. And this will give you the impulse. It is not a push, although you see that happening. We're going to take a contact, cross, get set, set our pelvis so we're strong, raise up and drop. The body drop with an impulse. And so we get a release. Well, thanks, Alan. If you'd like to go and have a seat. And Melinda, if you could come over. Just come around that way. I'll get you to lie on your back. If you can move down the table a bit. That's good. Melinda needs this out a little bit. There we go. So this time we're going to use a supine posture. And some of you will think, well, this is an anterior thoracic he's doing. Well, I'm not going to. I'm going to use it to get extension. So we'll be in the mid-thoracic again. Hands up over the shoulders so that we get a pull, not at the side. I want the traction of the pull. Get over onto one side with my knuckles. So it's not going to break a bridge. I'm going to be to one side. And I'm going to hold her to that side. On this side, I'm going to use my hand to make a donut so that when I place my chest on the tip of her elbow, I won't get a hit by her pointed elbow. My hand will block that with this little donut. I'm going to keep her slightly to the side. This will do P to A rotation and a little impulse, and I got the rotation to occur. Okay, thank you very much. Okay, in the upper thoracics, you come down a little bit. There you go. I'm going to do a thumb move. I'm going to block my thumb against the spinous. I'm going to rotate his head one way. I'm going to thrust the other. And I'll use the spinous to create rotation from P to A on the right side. Even though I'm contacting the TM, thumb move, spinous to the left here. So my thumb is right against the spinous. I'm going to take the head and counter rotate it. Get my sternum right near my thumb. And I will impulse with my thumb. Rotate the head the other way. Don't impulse on it. Just impulse your thumb, and we got a rotation move, T1, T2. Right, so let's review that again. We palpated that this vertebra didn't rotate, and we want to do a rotation in the upper thoracic spine. And we're going to use our thumb against the spinous. So we can go, 7 is the first long, we can block it, do 7 T1 or T1 T2, T2 T3. Our thumb blocks against the spinous, and we always, there's a rule of manipulation, you try and get your sternum as close to your hands as possible. This hand is going to be coming straight across on the spinous, and this hand is going to rotate those vertebrae above. So it's a rotation, counter rotation move. I get that out and do an impulse, and we get a rotation from the TM move. It's called the thumb move, TM move. Okay, if you could turn over onto your back. To get extension in the upper thoracics, we lower the headpiece. Bring the arms over the top again. Top arm on the outside so that I can pull him to get my hand in behind. And this time I'm going to use my thumb with a flat hand. I'm not going to make a fist. That tends to hurt. We're going to have a flat hand. I'm going to place it between the spinuses. So let's go 1, 2, thumb between, over into extension. Now quite a few patients, I don't even have to have them lift their head. And he's already started moving in extension. Others, I'll go one lower for this. Hold your shoulders. That's it. Come on up. I have this donut on his elbow. Come on up. Lift him a little bit to get the contact on my hand. Drop back, let your breath out. And as soon as he gets up over and is starting to extend down the table, I'll thrust with my sternum, little dropping of my body, and this will cause extension. If we wanted to do flexion up there, have the headpiece up a little bit, put your hands in behind your neck. This time, I'll have him come down the table a little bit more. Again, bring the elbows together, tilt him up, get the hands in between those spinuses, make that donut, get the speaker out of the way. There we go. Stay there and let your breath out. And impulse. And what's happening there is it's starting to separate in flexion. That move goes all the way down. Mid to lower. Come on up into flexion. Let your breath out. And impulse. And because he's flexed and I do that impulse, it releases to flexion. If I had the headpiece lower and I was in the lower spine, cross his arms, nice donut, come on up, get the tension. See how I moved him to get the tension onto my hand? Go back, and as he gets past, thrust for extension. Thanks a lot, Alan. This next maneuver is, adjustment is a little bit more difficult, and consequently it doesn't get done very often. But it's my experience, it's a very irritating fixation, and it causes a lot of sympathetic irritation. So if you're not looking for this in a patient, you won't find it. And if you don't find it, you won't try and get it to release with an adjustment. So this is lateral flexion. And I have the patient hold the table, hold themselves perpendicular to the table, and I'm going to take a double thumb contact over the spinous. I'm going to put my sternum on her shoulder. I'm going to compress thumbs and my sternum on her shoulder until I feel her thoracic spine trying to laterally flex. I'll be on a spot that I know doesn't, so when I do an impulse through my chest and with my hands, I'll get this vertebra to release and lateral flexion. So here we go, the spinuses. We know from palpation that it doesn't move very well. We'll get one thumb on, one above, sternum on her shoulder, push down, feel that resistance. Don't lift up, but thrust down. And you'll feel the spine go down, the vertebra should open up, and lateral flexion. That can go as far the 7, 8. Just move your sternum down a bit. Same thing. These are tiny little releases. It's audible release, but not the same as extension or flexion. It's just a little subtle release. Has a huge effect symptom-wise. Okay, if you'll lie face down. On some patients, you can take a cross bilateral. Feel the resistance. Set up for cross bilateral for extension, or if you're thrusting one, rotation. And just rotate around with pressure so that you can thrust laterally. Now you need to body drop. So the thrust comes out of your shoulders, and I got a little release that way. Just a little thrust. So it's very important that you practice that body drop where you come up and down be through your shoulders. This is not dropping your body. This is body drop. Comes from Carver technique. Okay, thank you very much, Melinda. Lie face down. That's it. Shoulders right there. For upper thoracics, for flexion, if we get a knife edge contact in between the spinuses and we take a traction out of the cervicals with the headpiece slightly lowered, so we get a knife edge between the spinuses, traction from the cervicals, one arm body drop. I'm going to thrust onto that knife edge, I'm going to push forward, and the combination of the two should open up the interspinous space. And it'll be that. Sometimes I put the drop mechanisms on. Take the same contact, I'll go one higher, take out the traction, straight arm so I can body drop, and get a dropping. That increases the thrust in that area. I don't know in either of them whether they really released on him or not. He probably doesn't need it. But I think on that second one I felt a little separation for flexion. For the mid and lower, now he's broken out in some sweat, so I probably did get that release, and we're now getting a sign that we've facilitated the sympathetics. And he's damp, yeah, everywhere. He's broken out into a sympathetic response, which is what we want in patients. This is how we get their health to improve. So let's say we're down here 9-10. Knife edge between the spinuses. Reinforce straight arms. Pelvis turn so I'm strong. In breathe, please. He lets his breath out. I'm going to thrust against that upper spinous and see if I can get some flexion, interspinous flexion. The hyperextension, anterior ligament. This is very difficult. I would know from palpation that this patient wasn't extending, hyperextending very well. I would definitely want an X-ray to know whether the anterior ligaments were calcifying. It's usually in a patient over 40, and so we have to know whether we're trying to get something to move, that it's already fused in the anterior ligaments, which is not uncommon. But if we find that there is no calcification, no lipping and spurring anteriorly, then we have to go very deep to get that extension. So we're going to raise the headpiece. This table's marvelous in that it'll go up into extension. I just have to lower the table a bit. There we go. So now you can see he's extending a little bit. He's extending a little bit here. I'm going to get knife edge right in between the spinuses. I'm going to push down, ask him to breathe, and I won't let him come up through my hands. I hold him in that down. Breathe out. He's going to go even more down. Take in a breath. I'm going to hold him there. Breathe out. And now at that point, I have to body drop. If you're lucky and you have drop mechanisms, when you do that body drop, the table will drop and magnify the thrust for you. I'll have Alan come over. If those two maneuvers don't work for hyperextension, I'll have the patient sit that way, facing that way. Well, let's do it the other way so the cameras can pick you up. Swing around. So what I'm going to do now, I'm going to place my thigh against the thoracics. I'm going to reach in and completely force his rib cage forward. So my knee is in behind his sacrum. I ask the patient to put their hands behind their neck. And if they're not too big, I can reach in through and get my hands in behind the ribs and bring him back. Bend yourself, that's it. He's a little flexed now, but he's going to become extended. And from that, I will thrust. And his headpiece has to be down a bit. There we go. So that my ankle can flex down. There we go. So now I got to get him onto my thigh. Hold the back of your head. I'll lift up his ribs. I'm going to bring his ribs into extension. I'm going to create a fulcrum with my thigh and impulse. And he feels the ribs move a bit, but he also gets a lot of extension through the thoracics. That's sort of a come or I'll fetch it move. I don't have to do it very often. I can usually get it through just the drop mechanism and extension. We haven't done with flexion, and I want to do that. It's a similar move we used. Come on down a bit. Okay, so what we've done now, as I was reviewing, was the thoracics from about the mid on up. But it's very important you get the thoracolumbar junction moving. And we did that with the lumbars, where I showed the upper lumbar L1, T12. Now this will be 12, 11, 10, 9, that area. So it's very same. Cross the arms over the top of the traps. We're going to make this donut so that my sternum go on that. I'll pull him over. I can get it, say, 9, 10 here. Come on up. Lift him to get him onto your contact. Now for flexion, I'm going to keep him here, breathe out, and I'll get flexion. Go back, and I'll get extension. So this move becomes not an anterior thoracic, it becomes a flexion move when they're flexed, an extension move when they're extended. And that covers the thoracics, posterior thoracic joints. So we've done upper thoracics for extension, rotation, lateral flexion, mid-thoracics combination, extension, rotation, lateral flexion, supine, flexion, extension, rotation, lower thoracics. We now have to consider the costotransverse joints, which are an integral part of the thoracic motion unit. You can't talk about moving thoracics. You're talking about thoracic joints, of which the costotransverse joint is an integral part of thoracic movement. Okay, what we're going to do now is, and we would have done this before we started adjusting the thoracics, but for demonstration purposes I've split it into two. But we need to now determine whether the costotransverse joints are free to move with the thoracic vertebra. So the first one is the first rib, and I palpate, if we can rotate around here just for a minute, I'll palpate just in front of the trap, just behind the sternocleidomastoid and just behind the clavicle. There's a nice little crevice here, and the first rib is palpable if I push down. That rib should move when the neck extends, rotates away, and laterally flexes towards. Now in his case, this rib is palpable. I shouldn't be able to feel the rib. It should feel like it's springy and moves away. Just so you see the head movement, I'll palpate the other rib. We'll bring him back, rotate away, and laterally flex. And he's also fixed here. So he has a bilateral first rib costotransverse joint dysfunction. This, if he was a patient, would constantly recurring upper cervical dysfunction, or lower cervicals becoming hypermobile, and that causing a radicular type syndromes down the arm. Maybe even causing flexion and A to P rotation of the cervicals, which would give you the sympathetic called the cervical syndrome. And every chiropractor should read Ruth Jackson's book called The Cervical Syndrome. There's 21 very significant symptoms that people go, neurologists, orthopedics, rheumatologists, and eventually they're called neurotics or hypochondriacs because the symptoms are so varied. There's pain, there's weakness, there's headaches, there's blurred vision, there's heart palpitations. Sounds like your classic hypochondriac. And all the time it's the cervical syndrome, and that patient needs those adjustments I showed of flexion and A to P rotation, which is what he has. So his first rib is setting up this cervical problem. The second rib and on down, I put the patient's arm over their shoulder and catch their elbow and rotate them. Slide away from the spinous and pick up the rib. Away from the spinous and pick up the rib. And here we have a lump. It feels blocked. It's the rib not moving with the transverse. And you can go all the way down. Some people will have trouble all the way down. Others will just have it through here or lower. Just feel the ribs moving. If there's local inflammation at the costotransverse joint, the intercostal nerve gets involved and you get an intercostal neuralgia. So the pain goes from the back and the patient feels it around here at the front. They don't even know the whole thing's coming from their back. If they do feel it all around their back and into their chest, they might have gone to the hospital thinking they have angina. And they'll be told that they don't have angina when all the heart tests are negative. And what they'll have is pseudoangina. It's an intercostal neuralgia from the fact that the intercostal nerve is being caught right where it moves through the costotransverse joint. So you'll pick it up as a lump block. As you slide out from the spinous, you'll get right on it. Of course, we'll just reverse that so you can see what I'm doing with his elbow. Pulling on the elbow, feeling if the ribs move. While we're at it and looking at the ribs, I can palpate between the ribs and see if there's intercostal motion. Now there's no joints here, but there's soft tissues, and it often people injure their ribs and 2 or 3 years later they're in your office and those ribs are just going and they're not separating like they should. And this requires specific technique to open up those ribs. Once you've discovered it's blocked at the back, go to the front and test the cartilages on the front. And I'm just using the heel of my hand, pushing, and when there's trouble front and back, it's going to be quite painful when you push, and you'll feel that it won't spring like normal costocartilage does there. So this is going to give us whether we need to adjust the first rib. It's specific. I'm going to show you that. And then we'll go second, third, fourth ribs. I'll show you that, and then we'll see how to adjust the lower ones. Okay, do you mind lying face down? Okay, we motion palpated that he has bilateral dysfunction of the first rib, the costotransverse joint with T1. And what I'm going to do first of all is on the left side here, adjust it with him prone, and then I'll adjust it with him sitting on the right side so you can see the two different methods. I'm going to use my index finger in front of the trap and just behind the clavicle and make contact with the first rib. So here we go. We get the trap out of the way, get in on the rib, and now I have to duplicate the palpation posture. That's kind of a rule that we use sometimes. I'm going to block my elbow against my knee so that I'm stronger. I'll pick up his neck and extension, rotate away, laterally flex. When he breathes out, I'll impulse. Try not to pull, push with an impulse. And see if you can get that first rib to release. Let's look at that from another angle. You'll see that I'm placing my index finger in front of the trap. There's the clavicle. I want to get down on that rib. I lower my hands, lower my body to get my sternum near my hand. I pick up the neck in extension, rotate away, laterally flex. That rib should move, and that's when I impulse on it. So that usually moves with an audible release, but in all cases, get into the habit of doing a palpation, figuring out what you're going to do, how you're going to adjust it, and then repalpate to see whether you actually achieved it or not. It could click with the one above or the one below, and you don't do what you think you're doing. So we palpate, extend, rotate away, laterally flex, and it's a tiny bit springy now. I wouldn't say it's normal, but I think I've mobilized it a little bit. Let's do it on the other side sitting. I'm going to put my foot up on the table. I'm going to put his arm at about 90 degrees onto my thigh. Some people palpate the first rib this way. They just block in on the first rib, not C7. You got to get out here behind the clavicle in front of the trap. You got to get where the rib is and just flex over and see if it can move. See if it can move. To adjust, we're just going to do that palpation. I'll get on that rib. We're going to just bring lateral flex till you feel that rib is trapped. Take a breath. So he's got to let out his breath so everything relaxes. That's it. Just let it go. And impulse. Impulse. Right in on the rib. Now you'll often get cervicals to release if you're over on 7. And we'll repalpate. And we've mobilized this level. It's still a bit blocked, but let's try the sitting method on this side. The arm rests. Just get right down on the first rib. Feel it blocked. Catch him on an out breath and let it go. And we've then got a release. So it was mobilized. Now it's actually had a cavitated manipulation. Why do we want to cavitate it? Well, there's some research that shows that when it cavitates, the afferentation is greater than when you just mobilize it. And we've known this for years clinically because patients will come where they've been to a physiotherapist who's mobilized it with not great results. They come to us and we manipulate, get a cavitation, and things start to really change. Because you know, the joint mechanoreceptors go to the brain. That's how the brain recruits to move the joint. So primary in joint movement is that the joint moves so that the brain can recruit the muscles that move that joint. If the joint isn't moving, there's no afferentation to the brain, and the brain hears afferentation from above or below, and so it recruits abnormally. It'll recruit other muscles to do the action that joint that was dysfunctional, hypomobile, wasn't able to do. And this is why we have primary and secondary fixations. If we don't get the primary dysfunction adjusted and change that afferentation, then we're just going to be dealing with the compensation, which keeps on recurring. So you should have a little rule. If you have to do the same thing over and over again, stop. That's right, stop. And then go and find out what's causing that to keep on recurring. There'll be a hypomobility, I can assure you, somewhere in the kinematic system. Okay, Melinda, could you come over? Okay, we're going to assume that we've palpated Melinda and we found the second, third or fourth costotransverse joint wasn't moving properly. And we're going to use what's called a combination move. And in this adjustment, we're going to have the arm hanging down. I'm going to take a pisiform contact out from the spinous where we palpated that rib. So let's say it's the second here. And I'm going to bring my pisiform in from the spinous and up against the rib. At that point, I'm going to rotate the head away until I feel tension at the rib. It just released, and it often does. But if it hadn't, I'm going to body drop, and I got releases through the lower cervicals as well as that rib, because those muscles coming off there go all the way up, and patients often feel when they turn their head, they get tension all down through their shoulders. And if you can get that rib to release and those lower cervicals, they'll be able to move their head without feeling this nagging pain just at the top of the scapula. This is a devil of a little pain, because you often adjust people and they'll stand up, they'll move their neck, and they'll say, "Doc, it isn't gone. It's still there," right? You didn't get it. Okay? Well, you'll get it when you do this. It's very easy. I'm going to go the other side and do the same maneuver. So we come out. There's the spinous. Slide from the spinous with the pisiform. Make contact with the resistance of the rib. The patient hangs their arm down. You take the head until there's tension under your pisiform. Don't take it all the way. Just a tension. Now you need to know how to one-arm body drop. And when you do, you get a full release all the way down through with those second, third, fourth ribs. Thanks, Linda. This will be for the same ribs, only this time the patient can't lie prone. And we're going to take a contact on the front of the ribs as well as the back of the ribs, and we're going to spring them both, and we'll get the costotransverse joints of 2, 3, 4 to move quite easily. So again, we just cross the arms. This arm allows me to get up. There's the spinous, get out by the rib. Can you see that? Put my knuckles along the rib. So I've got that trapped. Bring the patient there we go. Bring the patient at about a 45-degree angle till you'll feel your knuckles hitting against the ribs. Now come in and make contact on the front of the ribs, chest on his arm, impulse, impulse. The ribs are trapped on my fingers. I'm pushing on the anterior of the rib. It'll cause a springing. If it's female patient, have the patient put their hand over their breast so that when you come up this way, you put your hand on their hand to get that rib pressure. They'll be quite happy with that. There's no problem. Okay, so that's prone, combination, supine, patient at 45 degrees, impulse. Okay, now we need to do the lower thoracics. Do you mind coming back, Melinda? Arms crossed. This is the very same as up higher, only you'll see it's easier. Bring the patient over, find the spinuses, go over to the side, pick up the ribs, knuckles along in that space between the rib and the spinous. This time the patient's going to bring their ear up to this shoulder. You can even do it on the first one, but it's very important for this. Bring your ear up to the shoulder. That's it. And as they drop their head, impulse. And you'll get a release of the costotransverse joints on the downside, because that's where your knuckles are along those ribs. Would you lie prone? Okay. Now, if you've palpated a rib, a costotransverse joint, and you identify it with palpation, it'll be the lump and the pain. The patient will know, and you can ask them, is that where it hurts the most? Push superior and see if it hurts more or less. Push inferior and see if it hurts more or less. If it's hurting less, you're relieving that joint. And what we do is take a contact, cross bilateral, and rotate with the contact and thrust. And this should give the thrust headward, the way in which it relieved the pain. If it was relieving it footward, come in with the other pisiform and thrust footward. So we're going to do thrust headward for relief headward, thrust footward for relief footward. You counteract the rib on the other side. So this hand, just like a cross bilateral, it takes out the tension, and then you impulse. Intercostal. If you found that this patient couldn't separate their ribs, you take a knife edge, the ribs are at this angle, you take a knife edge right up along the rib. You see the angle I'm at? You thrust to cause a separation. There's no joint here. Sometimes you'll hear it move at the costotransverse joint, but you'll get a separation right between the ribs. Impulse. You might want to do some massage between those ribs, but they're usually pretty painful, and I like to start with something short and sharp, gets it to move, give the patient a little healing time before I really dig into the soft tissues. So now, there's one fixation left, and that's the costovertebral joint. This is very impossible to palpate. But what happens if you work with a patient, you're getting everything else to move nicely, and your patient will make this comment, it's consistent. Doc, the pain is in deeper. I feel like you're just not getting deep enough. And that'll be irritation at the costovertebral joint. I just continue to adjust the way I have been adjusting them, the costotransverse, mobilize, keep moving until hopefully I can get that costovertebral joint to move a little bit. There's no way of palpating it. You only go by the symptoms. And that pretty much wraps up moving the first rib, the upper thoracics, the mid, the lower thoracics, and the costotransverse joints. Specifically, to cause anterior glide. Could you go into Sphinx? That's it, arms down. There you go. It's really important that patients have this anterior glide of their upper thoracics. So when they're in this posture, you can feel, and with her, I can still feel there's a little resistance, and then it starts to get supple again. That failure of the thoracics to glide anterior prevents the head from coming into extension properly, and so C5-6 starts to become hypermobile, and as you know, it's one of the most degenerated joints in the body. It breaks down because it has to do a job that it wasn't designed to do. The upper thoracics are incredibly important. Okay? That's the end of the thoracics.